Okay, guys, so here we go. Here's our circulatory physiology lecture. So sorry that we had to cancel class. My aunt, who's really close to me, passed away, actually from heart condition. So really ironic, and tough to deal with. But yeah, just another kind of reason why it's so important to understand this. Okay, so last week, or no, 2 weeks ago, before our exam, we focused on the heart. Okay, so we know a lot about the heart. So now we're going to kind of expand that a little bit further now and talk about the circulatory system. So we know our heart pumps blood. Now we're going to talk about where is that blood being pumped, and how is it being pumped, and what is the purpose of this. So circulation kind of refers to how we circulate blood through our arteries, veins, and our capillaries. So we already know that our red blood cells found in our blood carry oxygen. Okay, that one's obvious. But the blood also is charged with transporting some other important elements, such as our hormones. Okay, so our hormones travel through our bloodstream and they are signaling molecules. So they'll travel to a certain organ or tissue, gland, etc., and tell it some important information. Okay, so beyond hormones, we also have water in our bloodstream that is going to be transported to the cells and tissues. And then, of course, we're going to have nutrients, right? Like glucose, proteins, lipids, whatever is needed, that is all going to be transported through our bloodstream as well. So, we've touched on the red blood cells, but now we're going to kind of back up and look at blood overall. So, blood is a connective tissue. So, we have four primary tissue types in our body. Okay. And I'm actually going to go over those first, just in case you guys are not familiar with that. So, all of the tissues in our body can be classified under these four primary tissue types. So, first one is connective tissue, second is muscle, third is epithelial, and fourth is nervous. So, let's look at the ones we were already familiar with first. So, I'd say muscle tissue is pretty straightforward. So, muscle is the primary tissue type, but under muscle, we know that there are actually three types. There's cardiac muscle, which makes up the heart itself, skeletal muscle, which are the muscles that move our skeleton, and then smooth muscle, which you're probably thinking of things like your organs, right? Like the GI system, uterus, etc. So that's muscle. There's three types. The next tissue that we've talked about already is actually nervous tissue. So when we talked about the nervous system, we talked about that there's two types of cells in the nervous system, or two types of I should say two types of nervous cells in the nervous system. Okay, so sorry, that was a mouthful. First off, we have the cells that are sending action potential. So those are our neurons. Okay, so that's one primary thing for nervous tissue. And then the cells that support the neurons but don't actually send action potentials, those are our glial cells or the neuroglia. So when you think of nervous tissue, I want you to think we have neurons and neuroglia. Okay, next, let's talk about epithelial tissue. So, epithelial tissue, essentially, these are the tissues that make up our glands, line cavities and organs in our body, and kind of like bind things together. Okay, so epithelial tissues are categorized by essentially the shape of their cells and how many layers of cells are in that tissue. So, if, for example, we say, it's a simple cuboidal epithelial tissue. Simple means single layered. Cuboidal means cube shaped. So that means that that tissue is a single layer of cubed cells. Or we could say stratified squamous. Stratified means more than one layer. Squamous means squished. So stratified squamous would be multiple layers of squished cells. Okay. And then the structure of those cells will determine the function of that tissue. Okay, so epithelial tissue, think of like your glands, like your endocrine glands, exocrine glands, and linings of cavities. Okay, now lastly, we have connective tissue, and this one tends to be really confusing for students, because it's kind of scattered. So essentially, connective tissue kind of encompasses all of the other tissues. I'm sorry, it encompasses everything that doesn't fall under these categories. So, connective tissue, in a nutshell, what makes something connective is that it has a bunch of cells embedded in an extracellular matrix. And an extracellular matrix, like the name says, it's the area, the matrix, beyond extra, the cells. So it's kind of like the background of the cells. Or another way to think about it is it kind of makes up the consistency of that tissue. For example, if the extracellular matrix is gelatinous, okay, like jelly-like, that means that that tissue is going to be very slippery and move very easily. If that extracellular matrix is calcified, for example, in bone, then it's going to be extremely, extremely hard. Or if the extracellular matrix is fluid, like it is in blood, then it's going to be a fluid tissue. So it kind of makes up like the consistency of the tissue. So regardless of the consistency, there's going to be a certain set of cells that are kind of resident to that tissue. Okay. So kind of abstract to think about, but when we look at blood, hopefully this will make a little more sense. So going back to blood, blood is a connective tissue, so it is a bunch of cells embedded in an extracellular matrix. Since we're talking about blood, oh, sorry, dog is barking. Okay, sorry about that. All right, so blood is a connective tissue. So the cells that we find in blood, of course, we have our red blood cells. Then we have our white blood cells, which are also called leukocytes, and then our platelets. Okay, so those are the actual cells, the cell part of the connective tissue. Okay, also called the formed elements, because those are the physical pieces that we find in blood. Now, when we talk about the matrix of blood, that's the fluid portion, which we call plasma. Okay. So remember, here's plasma. Plasma is essentially water, right? It's mainly water, but there's actually more to the plasma. So suspended or dissolved in the plasma, you're going to find things like ions, okay? Ions, certain gases, the nutrients, maybe like glucose or protein, and then also certain types of signaling proteins, okay? Maybe proteins that are going to help clot or even like hormones, right? So, plasma, again, is essentially water. It's the fluid portion, and it has things suspended in it, as well as our cells, red blood cells, white blood cells, and platelets. And that is what makes blood a connective tissue. Okay, so a little more detail into our formed elements. We've already talked extensively about red blood cells. Their job is to bind and carry oxygen to wherever the body needs it, which is everywhere. Okay, so red blood cells, they live about 120 days. So they do die off, but they do circulate for about, give or take, 120 days. So next up, we have our white blood cells or leukocytes. So here are all the different types of white blood cells, and you don't need to memorize like the function of each of them because they're all very specific. But generally, you should be able to recognize the names, right? So if you see monocyte, lymphocyte, eosinophil, basophil, neutrophil, okay, if you're looking at all the components of blood, you should know that those fall under the category of white blood cells or leukocytes. And in general, all of them have to do with immunity. Lastly, we have our platelets. So platelets, so these guys over here are actually the platelets, okay? Platelets are actually not true cells. They're actually fragments of a bigger cell, which is these like fuzzy looking guys over here. These are called megakaryocytes. Okay, mega because they're humongous. So, megakaryocytes, when they sense that we need to do clotting, okay, like maybe there's an open wound, then they will actually like kind of tear themselves apart. Okay, they'll break apart into little fragments, and those little fragments are what we call platelets. So, platelets are not true cells, they are pieces of a bigger cell called a megakaryocyte. Okay, so now let's talk about our blood vessels. So, Three types of blood vessels. First, I want us to kind of compare and contrast arteries and veins. So, arteries, we've already discussed that arteries take blood away from the heart. For the most part, that means that arteries are going to be have oxygenated blood, but we know that's not always the case. So, aside from that, now let's talk about the type of blood that's going through it, and more specifically, the pressure of that blood. Okay. So, when you look at the structure of an artery, when you compare it to a vein and capillary, notice that the wall of the artery is very thick compared to the vein. Okay, so here's the muscular layer in a vein and the muscular layer in an artery. So it's super, super thick. And hopefully you realize that, okay, well, this is muscle. We know there's three types of muscle. Can't be cardiac because we are not in the heart. Can't be skeletal because we are not touching a bone. So it must be smooth. Okay, so arteries have a thick layer of smooth muscle. And this is because arteries need to be very elastic. They need to move blood that's under a very high pressure, and they need to withstand that pressure. Okay, so those are arteries. Now, when you look at veins, veins have blood or they carry blood that is under a lower pressure. Okay, so think of just like a faucet, like when you turn the water on, just barely, and a water starts coming out slowly. Versus an artery would be if you turn on like a water hose and water spraying out at a high rate. So, because in veins, the blood is under a low pressure, we need to make sure we have a couple things in place to ensure blood stays moving in one direction. So we have valves. Just like in the heart, valves ensure that blood moves forward in one direction and doesn't go backwards and start pooling and create risk for clotting. Okay, so remember, veins have valves, arteries do not. Okay. So, before we move on, I also want to remind you guys that the circulatory system is a closed system. So, all of our blood is flowing through in kind of a loop. And we can let's start off with leaving the heart. Oxygenated blood leaves the heart via the aorta. And hopefully, you remember that the aorta is the biggest artery in the body. Okay, so it's a giant artery and it gives way and branches off to all of the other arteries in your body. Okay, so like brachial artery, radial artery, brachiocephalic artery, etc., etc. Okay, then arteries, as they approach an organ, right? When they're approaching an organ, they're going to have to get smaller. So they branch into arterioles, which means little artery. And eventually, arterioles become capillaries, which are right here. Okay, this is capillary bed. Capillaries are the smallest blood vessel we have. And this is where things can actually exit the bloodstream or enter the bloodstream. So it should make sense that capillaries are going to be kind of covering wherever blood is going to leave. Okay, so capillaries then, when you go away from a capillary, blood leaving a capillary is leaving via a venule or a little vein. And then we have all of our veins, of course. All of the veins in our body at the end of the day drain into one of two giant veins, our vena cava. Okay, so blood will either end up in our superior vena cava or inferior vena cava, and either way, all that blood will end up back to the heart into the right atrium. Okay, so that's what makes this a closed loop. So now to go into a little more depth, let's talk about arteries. So we know that arteries have blood under a very high pressure. So, because the arteries are so thick, right, they have such a thick layer, basically, by nature of just sheer space, the lumen or the space inside of that artery where the blood's actually flowing through, that diameter becomes a little smaller, right? Because this is so thick. So the lumen is a little bit smaller when compared to a vein, okay? Because of that, the total volume that we're going to find in our arteries, right? The total volume of our overall cardiac output, say it's 5 liters. Only about 11% of those 5 liters can be in your arteries at one point in time. Okay, and that's a rough estimate. Okay, but just so you can kind of compare when we talk about veins in a second. Okay, so we know that there's smooth muscle in the walls of the arteries. And in order to control that smooth muscle, we need some help from either our autonomic nervous system, right? And our hormones, okay? Or both. Essentially, your autonomic nervous system is going to send signals to these arteries to either constrict or dilate, depending on if you want blood flow to increase or decrease, right? And that just depends on what's going on in terms of homeostasis. Okay. Um, Most important thing to know about arteries is if you have cut yourself, right? If you're injured and you're bleeding, you will know that you've cut an artery as opposed to a vein or a capillary because the blood will spray out, right? If you cut an artery, okay, just like if you have a cut in a hose, right? Water is going to spray out because of that high pressure. And it's going to actually spurt out with your heart rate. And that is a major red flag that should immediately prompt you to realize that's a medical emergency and you need to stop that bleeding immediately. Okay. So to do so, this is where someone would use like a tourniquet, right, to cut off the blood or do whatever you have to do, essentially. Okay. So for example, you guys are probably a little too young to remember this, but back a couple years, I don't remember the year, but there was an incident at one of the Boston marathons where there was a bombing. So people were running, and obviously, when the bomb went off, their limbs were being cut off and horrific. Okay. So this guy, okay, got his leg blown off, and his femoral artery was left kind of hanging out. Okay. So he's bleeding out through his femoral artery, which is like in your thigh region. So it's humongous, okay? And it goes directly up to your aorta. So if you cut this artery, you're going to bleed out really, really quickly. So like, look how white he is. Look how much blood he's already lost, okay? Like compared to his color. This guy, Carlos Arredondo, a hero, can be seen literally clamping with his hands this guy's femoral artery. This is a stranger, okay? He doesn't know this guy. He just saw him bleeding out, not a medical professional, just looks like a cowboy, I don't know, and saved his life. And this guy went to live. He got him to EMS by clamping down on his literal artery. That is a hero. Yeah, crazy. Okay, so anyway, if you ever see that an artery has been severed, do whatever you have to do to stop that bleeding. All right, so now let's look at our capillaries. So when you think of capillaries, I want you to think one cell thick. Okay, capillaries are extremely small, thin, and delicate. Okay, so it's kind of easy for these guys to rupture. So if you like get a paper cut or like a, I don't know, just like a small little cut, that means you've cut capillaries. Okay, and blood will obviously just like kind of drip out, not spurt out. So, why do we want the capillaries to only be one cell thick, and why would we want them to be so delicate and small? Well, hopefully, you remember that capillaries are the site of exchange. The only way for things to get in and out of this, out of our circulatory system, that is a closed loop, right? It's closed. The only way out or in is through a capillary. Okay, so what I mean by that is you can't just have like oxygen leave through an artery or through the aorta, and you can't have a protein get just pushed into a vein. Okay, it doesn't work. Remember, there's a muscular layer surrounding that tube. Okay, not in a capillary bed. So, capillaries are the site of exchange for things like oxygen, carbon dioxide, nutrients, waste, water, everything. Okay. So we usually depict them like this in a capillary bed. But what they really look like in real life is like a tiny, 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 tiny tube. Okay. And you can see here that we have a couple red blood cells squeezing out of this capillary. Okay. Just to kind of show you in retrospect just how small a capillary is in relation to something like a red blood cell. Okay. So capillaries exchange. Okay. Lastly, let's talk about our veins. So veins, if you look at the lumen of a vein, it's a lot bigger than the lumen of an artery. And that's because the walls of your veins are very thin, right? That muscular layer is super thin. So because there's just by nature more space inside that blood vessel, veins can they can account for a bigger volume of blood. So about 60% of the total blood volume is going to be found flowing through the vasculature of veins. So we say veins kind of serve as like a reservoir for blood volume. Okay. Remember, again, veins, they lack pressure, so they must have valves to ensure blood goes in one direction. So if we're looking at, for example, veins in the leg, a healthy vein has a very strong valve and is supported by musculature, okay? Because the muscles in your leg, in this case, right? Your calf muscles, right? Those veins are going to kind of be interspersed in between different muscles. So when those muscles contract and relax, it's going to actually push on the veins and force blood up. And that's good because it's helping um, how it's helping to increase pressure of that blood aside from just what the valves can do. However, over time, these valves are just they're essentially made of like, well, connective tissues, but they have like collagen and things that can break down over time just by aging in general. So, for example, if you've ever seen someone with like varicose veins or you have them, if you've wondered why you're getting that, it's because the valves are kind of failing in that vein. And so your vein is kind of like collapsing and it gets that little squiggly type look to it, right? They're kind of falling. Okay. So, yeah, that is natural. It happens over time. Or like by lifestyle, like if you cross your legs a lot, that's not too great for the vasculature in your legs. But anyway, I digress. So, skeletal muscle pump, that is what I just described in terms of your muscles contracting and relaxing to help generate pressure in the veins to get blood to go back to the heart. So that's why if you're on bed rest or you're laid down for a while, um, you're going to have like some changes in blood pressure or maybe be at a higher risk of blood pooling and blood clotting, which is obviously not good. Same thing with the respiratory pump. Like when we talked about the respiratory system, we have muscles in the thoracic cavity, okay, that are going to contract and relax and generate pressure to push air and blood where it needs to go. Okay, so big takeaway about veins. So veins are under a low volume. Now, under low pressure. Because they're under low pressure and they are kind of collapsed, they are also very superficial, meaning they are very close to the surface of your skin. And that should make sense. You don't want an artery that could potentially get snipped to sit towards your skin, where it's very vulnerable. So, arteries are found deeper in your body, veins are found superficially. So, for example, like it's usually easier to see veins on people who are like obviously really hydrated and maybe like really fit, right? So all of these vessels you see on this dude here are all veins. Okay. These are veins. Okay. And if you touch them, you'll know. Okay. The consistency. So with that, I want you to know that when you get your blood drawn, okay, or if you are drawing blood, you are always drawing blood from a vein. Okay. And hopefully it makes sense that you would never draw blood from an artery because as soon as you take that needle out, you've just created a puncture or a hole that is now going to be spurting out and they could bleed out. Okay. So you always draw blood from a vein. And I'm talking about like venipuncture. I'm not talking about things like a PICC line. That's a whole different situation. Okay, so now let's move on to our blood pressure. So this is what this lab is kind of all about. Blood pressure, okay, is so important to monitor because it tells us about not only your heart's health, but the health of your vasculature. So you measure blood pressure to measure the amount of force that the blood is exerting on the walls of your blood vessels. And the main thing that drives your blood pressure is how your ventricle, specifically your left ventricle, is contracting. Okay, so ventricular contraction, especially the left one, is what is essentially generating your blood pressure, right? Because the pressure that is generated here in the heart gets transported up out the aorta and then through all of the other arteries that branch off of the aorta. So, just by nature, just by physics, that pressure is going to be dispersed down through this closed system, right? Energy can never be created nor destroyed. It has to be transported somewhere. Okay. All right. So, by nature of this like elasticity of our arteries, okay, they can expand, right? And they can contract to an extent. Okay. And so, how often you kind of pressure or stress those arteries is going to determine the overall health and longevity of those vessels. So, we're going to talk about what these numbers mean in terms of the top and the bottom. Okay, like when you say 120 over 80, the systolic is the top, the diastolic is the bottom. And we'll talk about where that comes from. Okay, so this formula is talking about arterial pressure, the pressure in your arteries. And it's just saying, where is that pressure coming from? Well, that pressure comes from, first off, your cardiac output, right? Which I've just explained comes from that left ventricle. So that's the biggest factor, plus the actual resistance of those blood vessels. So we call that arterial resistance. And that just means like how difficult is it for that blood to move through that vessel? Is it easy or is there some resistance causing it to kind of drag? So, for example, if you have something, if you're trying to like imagine a straw is an artery, it's a lot easier to sip out water than it is to sip up a milkshake, right? The milkshake creates more resistance. Okay. Same thing with your blood vessels. So it's a direct relationship here. Cardiac output goes up, arterial pressure will go up, your blood pressure goes up. Or if the resistance, the arterial resistance goes up, that's going to directly affect the resistance in your arteries. Okay, so to kind of explain that a little further, factors that are going to affect your blood pressure. Okay. So because blood pressure, okay, well, first it's affected by, like we just said, cardiac output, the amount of blood, arterial resistance, how thick or fluid that blood is, and now the actual volume of the blood that's moving. Okay. So blood pressure is directly related to your blood volume, which is just essentially based on how much water is in your actual blood, right? How much plasma do you have? So this can directly be affected by your hydration. How much water are you consuming? But more importantly, how much water are you actually retaining? Because you have to retain the water in the bloodstream to actually have an increase on that pressure, right? You can't just drink water and pee it out, okay? That would lead to a lower blood pressure. So, with that, blood pressure and water retention are controlled by things like your kidneys and hormones, which we'll talk about when we do the kidney lab. But it plays a huge role in your blood pressure. Okay. Now, not just the volume of that blood, but also the viscosity of the blood. And viscosity is kind of describing like the thickness and the consistency of your blood. So hopefully you can picture, right? Like you want fluid, smooth blood, okay, to be flowing through your circulatory system. You don't want thick, clumped blood. That's bad, right? That's going to stress the system. So, something that is viscous, for example, like honey or even like yogurt, that consistency, that's a viscous substance. So, if your blood becomes viscous or thick, that's going to obviously significantly increase your blood pressure. Okay, so you're probably thinking, like, well, how could your blood get viscous? There's a couple ways. So, for example, if your blood has a high content of fat in it, okay, like a lot of cholesterol, or if you have a lot of glucose, maybe you're diabetic, right? You have a lot of sugar pumping through your vessels all the time, that is going to make it thicker. Or being super dehydrated. If there's less water in your blood, now your blood is mainly cells, and cells are going to make that blood thick. Okay. Okay, so now just kind of looping it back to the heart. Okay, so let's talk about the factors that are going to affect blood pressure from the heart. So, if you remember, we have our Frank Starling law of the heart that talks about kind of how your heart can adapt to stressors. Okay, so again, transient stress on your heart is very good. Prolonged, consistent stress is not. So, how do we transiently stress our heart? Exercise. Okay. How do we consistently stress it, which is not good? Stress, like emotional stress. Okay. So, when you exercise, that will that is training your heart, specifically your left ventricle. Okay. And it makes that heart muscle more compliant, makes it stronger, makes it able to stretch more. So if it's able to stretch more each time it relaxes, then it's able to accommodate more blood. So that's called preload. Okay. So you can increase the preload. That's a positive adaptation. So if you can increase your preload plus the contractility plus your afterload, that's going to result in an increase in cardiac output, which is really good. Increase in cardiac output means you're able to push out more blood each heart cycle or each minute, I should say. That's the actual units, each minute. And an increased cardiac output is a positive adaptation. So more blood is being pumped out of the heart. Thus, that pressure is going to go up because by nature, if you increase the volume, the pressure will go up. Okay. And that pressure gets, like we've said, transmitted down the entirety of the cardiovascular system because you can't just destroy that, I guess, that pressure that was created. It has to go somewhere. And what happens is it gets sent down through all of your arteries, and that's how you measure the blood pressure. So keep in mind, um, aside from actual training, your actual preload and your cardiac output is going to be influenced by maybe what you just ate, or if you have or have not eaten, more specifically, or if you just had a lot of water, or if you just went to the restroom, or just your general hydration status, right? Because that's going to affect the volume of your blood. So, something to consider is the timing of when you take your blood pressure. Okay, so since we're not actually doing this in class, I'm going to announce an extra credit activity. So you can do your blood pressure at home. I'll give some like places where you can go, and I'll ask you to just like give an assessment of your health based on your blood pressure and give you extra credit. So, but also obviously this is fair game for the exam. So when you are recording blood pressure, hopefully, you've seen this situation before. You have a cuff, right? So they're going to wrap the cuff around your arm, not too close to the armpit and not too close to the elbow. Okay. That inflatable cuff, okay, is wrapped around your brachium. Okay, that's your arm between your shoulder and your elbow. So the artery that we are compressing here is your brachial artery. Okay, and that brachial artery is directly connected to your aorta. Okay, your aorta is obviously right off of your heart. So it's very close to the heart. So it should make sense that since we can't measure the actual pressure of the heart, right, it's super deep. We want to measure an artery that's as close to it as possible to get the most accurate measurement because the farther away you get from the heart, the lower that pressure will be in that artery, right? So, what are we doing here? So, you're going to wrap the cuff, have your stethoscope ready, and you're inflating that cuff. And again, you're cutting off the circulation of that brachial artery. Once you start releasing the cuff, you're going to start hearing these thumping noises. Okay. These sounds are different than the heart sounds, like the lub dub sounds we talked about before. These are called corticoff sounds. Corticoff sounds are what you hear when the blood is moving, essentially. Okay. When blood is squeezing through, that is what you're hearing. It kind of sounds like a whooshing sound. I don't know another better way to say that. Okay. So what we're looking at is two numbers, a systolic, the top, which is the pressure you measure when you start hearing the corticoff sounds. The diastolic is the bottom, and that's the pressure you measure when you stop hearing the sounds. And I'll explain in more detail on the next slide. Over here, we have the breakdown of what is a normal blood pressure, elevated, hypertensive, a crisis. Okay. So if now you can kind of assess when you see someone's blood pressure, what's kind of going on? Where do they fall in this breakdown? And this is for adults. Okay. If it's for babies or even like preteens, this would not apply. Okay. Okay, so let's go over the setup just so you understand, even though you're not actually doing the lab. So, first thing you always want to do when taking a blood pressure is check the clothing. So, they can't have like a giant puffy jacket. You can't put a cuff over clothes that's too thick. So, either you're going to take their arm out of the sleeve, or if they have a really, really like tight, I don't want to say really, really tight, but like I don't know, like a dry fit, maybe something like that, where it's very close to the skin. That could be okay. But to make it most accurate, you're going to want to do it on the skin. So first you're going to set up the cuff, ensure that the arrows are pointed where they're supposed to be, and this just kind of varies on the brand of the cuff. But you want to make sure that it's lined up with the brachial artery. Okay, so it's facing forward. Then you're going to make sure that your patient or the participant has both feet on the ground. They are not like crossing their arms or their legs, and they have their arm resting on a table. Okay. They don't want to be holding it up or have it too low because that's going to be incorrect. Your measurement's going to be off. Okay. So once you do that, then you're going to pump up the cuff. So you start squeezing it and you're going to increase it until the pressure on the gauge is over 120. If you don't go over 120, then you're not actually cutting off the circulation. You're not going to be able to get a correct reading. Okay. If you suspect that this person has really high blood pressure, then you're going to have to pump it up even further, right? Because what's going to happen is once it's fully pumped up, you are going to put your stethoscope right under the cuff to start listening. And there's a little bit of multitasking here. So you will start to slowly, and I mean slowly, release the pressure on the cuff. And what you're going to do is wait to start hearing the heart sounds. So once you hear the first corticoff sound, sorry, not heart sound, corticoff sounds, then you're going to check the gauge and record that number. Okay. You record that number, that's your systolic number, but you do not just let it go from there. Okay. Don't let it deflate. Continue to keep slowly opening the gauge, and you're going to keep listening to see when you stop hearing the sounds. Okay, so when you stop hearing the whoosh, then you will mark down that number, and that's going to be the the diastolic or the bottom number on the blood pressure. Okay, so essentially what you are measuring, okay, let me show you here. You are measuring the pressure when the cuff is opening. Okay, that's when you start hearing it. And then when you stop hearing it, that's when the blood vessels completely open. Okay, so this would kind of correlate to when the heart is resting, and this would correlate to when the heart is contracting. All right, so it's a little bit difficult to kind of quantify blood pressure in terms of statistics because it's two numbers, right? So to quantify someone's blood pressure and then like use it for data, we can do something called a map. Okay, so you can take the blood pressure and then calculate someone's mean arterial pressure, the map. And this is a measurement of the average pressure in all the arteries, okay, like throughout the whole cycle. Okay, so it's an average. So I guess it tells us a little bit less precise info, but it is going to help us kind of, like I said, quantify our data. So the MAP is calculated by your diastolic pressure in millimeters of mercury, plus 1/3 of the systolic pressure minus the diastolic pressure. So here's an example calculation. You should definitely know how to do that. And the number you get here should be between about 70 to 100. Okay, that is average normal for an adult at rest. Okay, and again, I'm emphasizing at rest because when you exercise, obviously, blood pressure is going to go way up, and that's okay because you're exercising. Okay, so let's talk about what happens if your blood pressure, specifically here the MAP, was less than 60. This indicates hypotension, okay? And you can say someone is hypotensive in this moment, or you could say they have like primary hypotension, which means that chronically they have it. Excuse me, sorry. Okay, so again, if it's just one point in time, that's just one point in time. In order to be diagnosed, you have to like measure this on multiple occasions. So, why is hypotension bad? Well, essentially, some symptoms of hypotension would be like if you ever have stood up too quickly and all of a sudden you get dizzy and you see stars and you kind of can't see. What's happening is your blood pressure is too low. Okay, you haven't given essentially enough time for blood to reach your brain. Not only enough time, but essentially what happens is there wasn't enough pressure generated in your cardiovascular system to overcome gravity and get to your brain to perfuse it with blood and thus oxygen. So a low blood pressure is going to impair blood flow, to the brain. Okay. And that's bad because your brain's no longer getting oxygen. And that's why you feel dizzy or you pass out or you see stars, right? Because your eyeballs are also right there by your brain. And if they're not getting oxygen, they also won't work. Okay. So this is bad, right? Not a good thing. But to fix it, like how do you fix hypotension? Okay. Obviously, there's medications and stuff. But what your body should be doing is compensating for this. To get you back to homeostasis, you would want signals to be sent to your arteries to constrict, right? You would want them to constrict to increase the pressure, okay? But sometimes your body doesn't get that signal or it's unable to constrict enough, and that will result in the hypotension. Other things you could do are increase your hydration status, right? Like you want to increase the blood volume. So to increase blood volume, you want to obviously drink enough water, but not just water, also have enough electrolytes. Because when you drink electrolytes, they go into your bloodstream and they are osmotically active particles. So who will follow electrolytes? Water. Okay. Water always goes to where there's a lot of stuff. So this will mean that water is going to be drawn into your bloodstream and thus increase the volume of your blood. And that will hopefully pump up your blood pressure. Okay, so now let's talk about hypertension, the opposite, blood pressure that is too high. So if the MAP is over 100, that is bad, okay? If it's chronic, okay? That's okay if it's right after exercise. So what causes hypertension? Okay, so hypertension is when the arteries are there's a couple ways this could happen. Essentially, though, the bottom, like underlying cause is that the diameter or the lumen of your arteries has significantly decreased. So there's not enough space for that fluid. So what happens is the fluid is exerting an extreme amount of pressure onto the walls, okay, because you have lowered the volume. Remember, there's an inverse relationship between pressure and volume. Volume goes down, pressure goes up. And that is bad long term because you are stressing those arteries. And your arteries have to last you your whole life, okay? They are meant to be stressed, but again, transiently. If you do this chronically, then the baroreceptors, which are receptors that sense pressure, they kind of get burnt out in a sense. They're just consistently sending a signal that blood pressure's high, blood pressure's high. But it kind of, at some point, they kind of slow down or down regulate the signal or that warning signal because they're just like, okay, you're not listening, like nothing's working. I kind of give up, which is not good because now you're not being signaled that the pressure's too high. Okay, so what does this do over time? Well, this is going to lead to weakness in your blood vessels and thus in your tissue. Okay, and what does that do? Well, it also puts extra strain on your heart if that resistance remains high. Okay. So this is why if you have chronic hypertension, chronic high blood pressure, this puts you at a significant increase for so many things like an increased risk of a heart attack, increased risk of heart failure, increased risk of a stroke, increased risk of kidney disease or even kidney failure. Okay, blindness, just to name a few, right? Increased blood pressure is going to affect almost every single system in your body. Okay. And some of these things obviously can lead to death. So it's very, very important to recognize hypertension and do something about it. Okay. It is known as like the silent killer because we don't take our blood pressure very often, right? You can have a high blood pressure for a while and not even know. Okay. It's not like heart rate where you can really feel the difference. So please make sure you and your loved ones are consistently checking in on your health, specifically your blood pressure. It's super easy. It's not painful. It's cheap. You can go to CVS or Walgreens and do it for free, or you can just get a monitor on Amazon. It's just a really good thing to do. Okay. So I like this visual here to kind of really explain what's happening inside the vessel. So here's an artery at a normal pressure, right? Normal diameter, you can see here normal diameter. We have our red blood cells going through about their business. Now, let's say the pressure starts getting increased, the blood pressure, chronically. Okay. So now you are consistently stressing the walls of your arteries. Okay. So eventually, what happens over time is the arteries lose their elasticity and they lose their strength and they start to tear. Okay. I don't mean tear like a rip, micro tears. Okay. So you start developing little micro tears in the walls of your arteries. And your body is going to see this as injury. What do we do when there's an injury? Send help, inflammation. Okay. And that's usually helpful. But in this case, it's sending things like platelets and cytokines and things to kind of clot that injury. But that is also not helpful because what are we doing here? If we're building up things to stop a clot or re-strengthen that vessel, now the diameter of that blood vessel has gotten smaller. There is now a smaller area for blood to flow through. And as a result, the pressure has now like doubled in this artery. And that's not good. Okay. It's kind of your body's trying to help, but it doesn't. Okay. So that's where it kind of starts. But now it can get even worse where you can build a plaque because say you have hypotension and you have high cholesterol or high, like you're diabetic, you have tons of sugar coming through that sugar and those fats are going to pass by that injured spot at some point. And it kind of is almost attracted to that spot because it becomes very jagged. And so instead of the blood and the stuff in it easily floating by, they could get stuck. Okay. And the more things that stick, the more they clump and clot and clot. And if it's something like fat, it can harden and calcify. Then you get a plaque. So this artery has a huge plaque. And now look at how much space is left for blood to actually flow through. Plus, this is like cement, right? So you are now pushing against cement against a muscle. That is going to stress it even more. At some point, it's going to rupture. And if this artery was in your brain, okay, that could lead to a blood clot or even a stroke, right? Or in your eye, okay, could burst in your eye, that could lead to vision loss, could burst in the kidney failure, okay? So many different things could happen here. All right, so this was for the actual lab we were doing, but obviously doesn't apply to you. We are just comparing blood pressure between a active and sedentary individual before and after exercise. So I will post the data shortly for R, so that way you can see the results. And then these were just more tips for getting a good blood pressure reading. So you can use these if you are going to do this at home. All right, so what is due? So we don't have a normal like lab assignment for this week. We're kind of, I want to help you out a little bit. I mean, get you points and get you started on your major lab report. That's due mid-November. So that way you guys don't procrastinate. So your homework assignment is to go into R and make one table and two figures. Okay. So you're going to go to Canvas and download the MLR, Major Lab Report, R Markdown, and these CSV files. Okay. These three files are to make the table. These two files are to make figure one and figure two. Okay. So this is the format I want for the table. So you're essentially going to say, okay, if I'm comparing QRS interval before and after exercise, hint, hint, before and after for all of these, what test am I running? Okay. You're going to run these tests in R and then fill out their means and the p-values into this table. And that would be your table one. And then just obviously make a little figure caption like we always do. And then figure one and two, nothing has changed. This is what we've been doing every week. Okay. Just going to use R like always, decide what test to run the test, make your captions. That is it. Okay. So there's no discussion this week because, like I said, this is just getting the figures done for your major lab report. Okay. And those instructions will also be posted so you can review them and even get started at this point. But again, remember, you have a couple weeks to do it. So definitely read over the instructions. Let me know if you have questions, and I will see you next week. That is all. Thanks, guys.